Dr. Hart. He's the director over the emergency medicine and the residency program at Integra Southwest. He's going to do the lecture over electrolyte disturbances, yes.
Can you send us a PowerPoint?
Did it not just?
It's on YouTube.
Oh, is it?
It doesn't give you the notification.
Oh, okay.
Sorry. Thank you. Absolutely. All right.
All right, so I'm Chris Hart, I'm an emergency medicine physician at Integra Southwest Medical Center. And I'm happy to be here with you guys. How many people in here are interested in emergency medicine and this is just required? Things are required. All right, so the rest of you can just go home. So we're going to talk about electrolyte disturbances, and I've got 2 hours, so sit down, get comfortable. It won't take that long. This is obviously hugely important. You know, it seems everybody that checks into the emergency room gets a basic metabolic panel checked. I'll tell you, one of my pet peeves with our residents when I'm working with them is not everybody needs a blood test. Know what you're expecting to find before you order that test, okay? Another pearl I'll tell you is don't ask questions you don't want to know the answer to. And so sometimes ordering tests is asking questions that you might not know the answer to, not want to know the answer to. So, you know, ordering a white blood cell count on a kiddo that's got a fever that now you get a 16,000 white count, now what are you obligated to do with that? So kids bump white counts if they cough too hard, so don't go chasing white counts for no good reason. This is a little bit different setup than I'm used to. I feel like I'm going to be pointing up here all day and you guys aren't going to know what I'm pointing at.
There's a stick on the cord.
Man.
Super fancy. Or you can use your mouse.
Now, this is a Methodist school, right? So do I? Is that only Catholic schools? I see that. Okay, so first off, big thank you to Tammy in the back of the room. She helped put these slides together, did most of the work on them. I went through and added some not useful stuff here and there to make it my own. But I figured if she's going to be making the test, you guys probably want to know what she thinks is important. So I have no financial disclosures, although if anybody has any offers, I'll be happy to entertain them. I am an emergency medicine physician and not a nephrologist, so don't be expecting a lot of physiology words. I'm sure you guys don't believe in drinking games, but a drinking game, if I say a part of a kidney, that means I need to take a drink, and you guys can just think about the kidney for a second, okay? We won't be talking much about basement membranes and a little on ion channels, but that's about it. So this is what I do. We have currently 33 residents in our emergency medicine residency program. I have people from all over the country. A bunch of jokesters. It's kind of herding cats, but it's a lot of fun. Helps keep things interested. It's a busy ER. We see a lot of people. South Oklahoma City. It's a pretty underserved area, so we see a lot of pathology. It's pretty fun. So our objectives, we're going to talk some about potassium, sodium. Those will be the places we'll spend most of our time today. And then we'll do some brief overviews of calcium and magnesium, talk about some testing, and then also about some management. So I encourage you guys, when you think about potassium, think about kidney, okay? So potassium problems are almost always going to be kidney problems, all right? And we'll contrast that with something else in a little bit. So I'm from McAllister. I'm very comfortable with potassium, particularly high potassium, high IV potassium administration. I went to high school there, did my 4 years and got out for good behavior. But obviously this is part of, you know, the lethal injection cocktail that gets given. So hyperkalemia is a serum potassium greater than 5.5 in adults. Higher than 7 can lead to hemodynamic neurologic consequences. Exceeding 5.5 is really bad. Okay, so what does potassium do when it gets to these levels? What organ do you guys worry about?
The heart.
Good. So the heart's, it's all about the heart. So 90% of potassium is intracellularly, and most of the time that's where we want to keep it. There are some things that can shift that. So you guys know what's one thing that can shift that balance? So insulin can. How about another metabolic state? Good, so if you have an acidosis. So remember, an acidosis means I've got too much protein, which is an H+, floating around in my blood. The cells say, well, I don't like all those H+, I got lots of K+ in here, I'm going to trade them. The body really likes homeostasis. It's always trying to keep things balanced. So if I take an H+, I got to get rid of something with a plus. So it throws out a K+, and so then your serum potassium can go up. Your total body potassium may stay normal. And in fact, as an aside, if you take something like diabetic ketoacidosis, the patient's total body potassium will be depleted. So as those cells take in an H+, throw out a K+, the kidneys look at that and say, oh my gosh, we got too much K+, what can I do with that? I can pee that out. So while in a diabetic ketoacidosis patient, the serum potassium may be high, their total body potassium may be low because they've been peeing out all that extra potassium circulating around. And apparently that excretion happens at the distal nephron, and I'm sure I knew that. So again, most of it's intracellular, a lot in red blood cells, a lot in muscle, gets excreted in the GI tract and the kidney, and we'll talk some about why that's important in a minute. So that first cause for hyperkalemia, lab error, is very common. Okay, so you know, if your nurses are only able to get a 24 gauge and a pinky, and they're trying to draw lab work out of it, frequently they end up having some hemolysis on the test. Wherever you end up working, wherever you end up sending your lab test to, I'd encourage you to find out how they report hemolysis. Different labs do this in different ways. Some will report 1+ hemolysis, 3+ hemolysis. Some make you call and find out if there was hemolysis. But hemolysis is the most common cause. So if you get an elevated potassium, particularly with normal kidney function, and it surprises you, ask yourself, could this be a lab error? Okay? If they're indeed tagged, don't assume that. But if the patient's perfectly fine, you know, ask yourself if this could be lab error. It's not uncommon that we will get patients sent in. We've had some come by ambulance because their doctor called them and told them their lab was abnormal and they had something and they could die. And they get there and they had lab drawn last week that showed a potassium of 9, and they've been perfectly fine. And now they're there expecting that they're going to die. We redraw it and their potassium is 3.5, and they had a bunch of hemolysis. So just remember that. I mentioned when we think about potassium, what organ do we think about? Kidney. So renal failure can cause it, and that's going to be your most common cause. Particularly now, you know, as the dialysis population goes up and up and up, we see more and more of these chronic renal failure patients. So you're going to see a lot of it with renal failure patients. Cell death, so I mentioned, you know, there's a lot in muscle. So patients who've had burns, crush injuries, tumor lysis syndrome, they can get hyperkalemia as well. Of course, if you're taking potassium, then you can get high potassium. Generally speaking, and I've not tried this, but it's hard to take enough oral potassium to get a critically high potassium level. Generally, the bowel at some point will stop absorbing it and it'll just start passing it. But remember, that can be a cause, particularly if it's in conjunction with something else. So propranolol and succinylcholine, you'll hear about this. It's talked a lot about in rapid sequence intubation if you have a patient with hyperkalemia. If they have renal failure, you also see reports if they have burns. People with chronic neuromuscular disease, succinylcholine is probably not a good idea in those patients. Digoxin, we'll talk a little bit about that in a minute, but digoxin, if they get dig toxic, then they're even more sensitive to potassium, and it can be more dangerous. You might think of a potassium-sparing diuretic. Aldosterone, or spironolactone aldactone is the trade name for it. You're seeing that a lot. It's good medicine, used a lot for heart failure. They even use it some for acne because it does have some testosterone blocking properties as well. That can cause hyperkalemia. ACE inhibitors, and then pentamidine, you might see that. And trimethoprim is getting used a ton right now because of all the community-acquired methicillin-resistant staph aureus. So remember those medicines. Pseudo hyperkalemia, so I talked about if the sample gets drawn too forcefully, also if it gets left sitting around for a long time, if you shake it, roll it, throw it, that kind of stuff, you can get it. Severe leukocytosis can also lead to it. Okay, so I said whenever we think about potassium, we got to think about kidney. When we think about high potassium, the organ we worry about is the heart. So EKG findings are what you're going to be looking for. You'll see peak T waves, widening of the QRS, loss of your P wave, eventually sine wave, and then you can see ventricular fibrillation asystem. So here are some rough ranges of where you might see these changes start to occur and kind of what they look like. There's another representation of it. You can see at the bottom how it's starting to widen out. And this is what I've always thought is the best way for me to remember it. I tell people I'm an ER doctor, I'm not a smart man. I got to boil things down to something that I can remember. So when I think about hyperkalemia, I think of your tracing as a string. The first thing that's going to happen is somebody pulls up on your T wave, you get a peak T wave, then you grab the string and you just start pulling it out. And everything starts to widen until you end up with a sine wave, VFib, VTAC, and then asystole. So our treatment for that, we want to use membrane antagonism. We'll talk about all of this. There's different ways that we treat this acutely. There's several slides about it. So the mechanism for stabilizing the membrane, we want to decrease that resting potential in the heart. Calcium is how that can be done. It says on here that the decision to treat it that way varies by clinician, and that's true. Generally, I don't treat this unless I'm seeing EKG changes or it's somebody that I think I'm not going to be able to treat their potassium very well. So if this is a dialysis patient who I know has high potassium and is going to have difficulty getting this out unless we get them to dialysis, I may have a lower threshold for giving calcium. There are some people who would say, what's the problem with giving some calcium? Just give it. It's not your calcium. Let them have it. Probably not wrong for that either. Yeah, good. So obviously if the patient's in cardiac arrest or has a sine wave, you want to give it. Does anybody know the difference? So when I was in medical school, they always thought you give calcium gluconate, calcium gluconate, calcium gluconate. And I got into residency and they said, why do you always want to give calcium gluconate? And I said, because I passed lots of tests for calcium gluconate. Anybody know the advantage to calcium chloride? So calcium chloride has 3 times the calcium of calcium gluconate. So that's the upside. Anybody know the downside to calcium chloride? Calcium chloride has 3 times the calcium of calcium gluconate. So really calcium chloride, you worry about extravasation, okay? So your hospital may have the policy that calcium chloride has to be given through a central line. Calcium gluconate can be given through a peripheral line. So if they can't get a line, and you're still working on getting a line, calcium gluconate can be given peripherally. And depending on your hospital, you may or may not be able to give calcium chloride through that peripheral line. But calcium chloride has 3 times the calcium that calcium gluconate does. And that's a pearl. Is there a way to do it so I can see what slide's coming up next? Like a presentation?
You should be able to put it into presentation mode.
It'll just, I know how to do it on the Mac, I'm not sure on here. Oh well, it'll just be a surprise for all.
There's a presentation
Keep it
ready.
interesting. Okay, so we mentioned earlier, I think over here mentioned that you can give insulin, and that can treat your hyperkalemia. So insulin drives potassium into the cell. Usually I'll give 10 units IV and then plus minus given glucose because oftentimes these are diabetic patients and they have a sugar of 500 anyway. But you certainly don't want to make somebody hypoglycemic by giving them 10 units of insulin IV. The thing that you can use are beta agonists. Generally it's a 20 milligram treatment, which for most places is going to be an hour-long treatment. This is nice because you don't have to have an IV for it. Respiratory can throw it in there pretty quickly, and you can get your serum level down with that. IV sodium bicarb can be given as well. Really only works if they're acidotic because of that discussion we had earlier about there's lots of K+, I got to get rid of it and switch it with my H+. So if you can treat their acidosis, you may be able to lower their potassium level that way. K-exalate is a binding resin. If you like your nurses, you give it oral. If you don't like them, you give them 40 milligrams PR. It theoretically binds up the potassium. In real life, I believe the study that somehow has been used to base the FDA recommendation for this had like 12 patients in it, and they were using a diet of like Karo syrup. It probably doesn't work that much, except that if it has sorbitol, they get diarrhea and probably poop out potassium that way. Although there is a risk now that's been identified of colon necrosis with the sorbitol in it. So my practice is I don't give it unless the nephrologist says, and give them some K-exalate. I'll tell you, nephrologists love K-exalate. They'll give patients buckets of this stuff. But for me personally, I don't give it unless it's at the recommendation of the nephrologist, and I document that in my chart. Okay. Lasix. So you guys remember loop diuretics oftentimes require potassium supplementation. So these patients, if you give them some potassium or some Lasix, you may be able to get them to pee out their potassium. And then of course dialysis. So the way that in that first slide we kind of broke it down, there are really three things that you're doing. You want to stabilize the heart, then you want to hide the potassium. So that's what your insulin, your bicarb, your beta blocker, what all of those medicines do, and then you got to find some way to get potassium out of the body. So that's what maybe not K-exalate, but Lasix and dialysis will do for you. Here's a study that was done. They had 154 hyperkalemic patients. A significant percentage of them were over 5.9. ACE inhibitors and Bactrim were the most common causes. Kidney function was seen in 70% of them. Sent on EKG was done in 44% of the study patients, which seems low. Potassium-related changes weren't seen in 50% of the patients, despite levels over 6.5. The numbers I've heard have been that 20 to 30% of the patients may show EKG changes. So remember, don't get an EKG and say, well, I know they missed dialysis for the last 3 weeks and look kind of sick, but their potassium's fine because their EKG's good. It's not 100%, but certainly EKG changes need to be treated immediately. And the other thing is, if 70% of these patients had decreased kidney function, dialysis patients tend to tolerate hyperkalemia pretty well because they get it a few times a week, right? So I suspect that's why they seem to tolerate this well. So this is a patient that I actually had in the emergency room. It was a 48-year-old who came in. He just hadn't been feeling good, been throwing up, felt run down, had a history of heart failure and was on digoxin, Lasix, and this was his first EKG. And I'm telling you guys, this is the closest thing to a sign wave in a living patient that you're probably ever going to see. So I called the card, I got this, and then got some lab. His digoxin was high, so remember we said earlier that digoxin can make people more sensitive to their hyperkalemia. So his digoxin was high. His serum potassium was 7, and his creatinine was like 3. So he'd gone into renal failure, which drove up his digoxin and drove up his potassium. So I started treating him, and I called the nephrologist, and I called the cardiologist, like, yeah, and I said, no, look at the chart, and he looked at the EKG and said, oh, I'll be right down. He's a funny little excitable guy. Comes down. So this first one, it was at 11 o'clock. You guys can see that. So he gets the whole thing, with one exception. So this was way further back than I want to admit. I think in 2008. So there is a mantra out there that in patients who have elevated digoxin levels, if you give them calcium, you can cause what's called the stone heart. So remember that the digoxin stops migration of calcium in the endoplasmic reticulum, and so you build up some calcium, so you get a stronger beat, so theoretically it helps in heart failure, it increases your ejection fraction. Doesn't decrease mortality, but keep people out of hospital more was the thought. Less and less of it's being used. But anyway, so the thought is if you give calcium in hyperkalemia, you can increase, in patients who have a high dig, you can increase that calcium even more, and you lock things up, and apparently your heart turns into stone. My understanding is this was based on a dog study. It was never really shown to happen in adults, in people. So, not that kids are dogs, but in people. And so use caution, know that theory is out there. It's probably not true. And this guy got calcium. He also got Digibind, which is an antibody to digoxin that binds it up and helps to block the effects of dig, just for another talk. But anyway, he got Digibind, got calcium, and this was his EKG an hour and 48 minutes later. It was pretty impressive. He actually got discharged. His kidneys bounced back. I think he'd been building a fence down the tunnel or something like that. So if you're a mnemonic person, this is a mnemonic that I actually just heard. C, big K, die. Okay, so calcium is your C. B stands for bicarb and beta agonist. I for insulin, G for glucose. K is for K-exalate, and I guess LASIK, if it's not the eye surgery, but if you think LASIK sounds like it has a K at the end, even though it's an X. That's the K, and then dialysis. Okay? So if that helps you remember that, C, big K, die. Make sure it's true EKG, or true hyperkalemia. Remember your EKG findings. Give calcium. Don't forget to find what's causing it. Okay? Any questions on that? You guys stop me at any point. I'm used to having 36 residents who don't mind asking me anything at any point about anything. So if something's not clear, I'll confuse it some more for you. Hypokalemia, so generally less than 3.5. Severe hypokalemia, less than 2.5, can be potentially life-threatening, and this can be caused by us. So I'll give you guys another. So this is I'm not going to be able to ask PIMP questions anymore if I keep giving out all my PIMP question pearls, but if you guys ever get asked a PIMP question, you just really don't have any idea. But the question says, in the United States, what's the most common cause? You guys know what the answer is almost always going to be?
Diabetes?
It's iatrogenic, right? So in the U.S., we overtreat everything. So if somebody gives the distinction that in the United States, then it's probably that we did something to them, okay? How about most common cause worldwide? It's TB. It's just always TB. TB is so rampant around the world and causes so many screwy things that if that's an option, just pick TB. Otherwise, just iatrogenic. Hypokalemia, they'll get muscle weakness, can affect respiratory muscles. It can get some EKG changes we'll talk about in a little bit. And then you need to see what their pH is, because just like we talked about with hyperkalemia, with hypokalemia, it can be a result of some acid-based abnormalities. There's also a paroxysmal hypokalemia that can occur. As I remember, it's more common in Asian populations and is a familial disease, don't quote me on that, but patients can come in with profound muscle weakness and have a transient hypokalemia that then bounces back, and it may be that even by the time you see them, their potassium's back up. It's usually not life-threatening, it's frightening, they bounce right back, it's hard to catch, and they may need to be on a little bit of supplementation alternative. They usually do fine. Again, iatrogenic, so mostly it's going to be from thiazide diuretics, which we'll be talking about a few times today. Lasix can cause it, nausea, vomiting, diarrhea, high aldosterone, cortisol levels, acid-base abnormalities, renal tubular effects, magnesium deficiencies. Sorry, that picture kind of covered up. That's probably not important stuff. So decreased intake and then increased loss. So you can lose it through your kidneys, as we talked about already. One important cause that renal tubular defect, so type 1 renal tubular acidosis can be seen in huffers. You guys know what huffing is?
Like paint?
Don't act like you don't know. I don't want to encourage anybody to go buy paint this evening, but paint, glue, other solvents has toluene in it. Some people will huff that to try and get high. It can cause a type 1 renal tubular acidosis, and the most profound hypokalemias I've seen have been in huffers. The guy that came in and looked like a Tin Man one time from The Wizard of Oz, just completely silver all over. So metallic colored paints have higher toluene levels than other colors of paint, and so oftentimes you'll see gold, silver, copper, those kind of things. And he just was adamant he hadn't been huffing or anything. He was painting fence for the government now that Tinker was historic. So GI loss, nausea, vomiting, diarrhea, laxative abuse, again diuretics, amphotericin B, which you may not ever see in your career, mannitol, aminoglycosides, the transcellular shifts, just like we talked about a minute ago. So they can get some arrhythmias. Mostly what you'll see though is musculoskeletal pain, muscle weakness. Again, the paroxysmal hypokalemia, they can get levels less than 2 and come in almost paralyzed. We have one huffer who I've seen her potassium at 1.2 before when she comes in, and she usually complains that she hurts everywhere. So her muscles are screaming. She's not quite there enough to stop it. There you go. Got ahead of myself. So remember toluene in huffers. So if anybody's been huffing, I ought to just check a BMP at the very least on. Start to see changes on your EKG at about 2.7. You get a prolonged PR, flattening of the T wave, ST depression, and then what will probably be on your board test is a U wave. The only time I've seen a U wave was again a tox patient. We had somebody in the ICU who was being treated for a tricyclic antidepressant overdose, which you treat with sodium bicarb, and they over alkalinized him up there in lab call with a critical pH of I think it was like 8.2. So my first comment was get a rhythm strip, and they did have a U wave because their potassium had dropped down to like 1.5 over the course of a few hours. So they had some other stuff going on as well. But anyway, U wave is probably what will show up on your test. And that's what it looks like, right? So you got your QRS, then a T, and then next comes a U. So replacement, most people you're going to be able to just do oral replacement on. Occasionally you will need to give IV potassium, but remember you're not McAllister, so you got to be gentle with it. Generally, most hospitals' protocols will allow you to give up to about 20 milliequivalents in a peripheral line. If you're starting to get over that, they may require you to put in a central line because it is fairly caustic and irritating to the vein. Some patients will complain about burning with it. Again, some hospital protocols will allow you to mix a little bit of lidocaine to try and help with that, but generally it's tolerated. just want to get them back up 4.5. So another thing, anytime you have a profoundly hypokalemic patient, you always need to see what their magnesium is, all right? I'm not a nephrologist, but somehow in the kidney, it matters if they have enough potassium that helps them keep their, magnesium that helps them keep all their potassium. So you'll see that in alcoholics. That's probably the most common population that you'll see hypomagnesemia. But if somebody has a profoundly decreased potassium, check their magnesium and you may end up needing to replace that. My group, any questions? No? By the way, bananas don't have really all that much potassium in them. Apricots actually have more potassium in them than bananas. And over-the-counter potassium pills, if you have a patient who says, you know, I bought some over-the-counter potassium, it doesn't have all that much potassium in it. I'm not a pharmacist, but I sat down with one and we did all the math. And generally with K-Dur that we prescribe, it starts at, if you can get 10 milliequivalent tablets, and this came out to like 2 or 3 milliequivalents in the over-the-counter. So they'd have to take buckets of it for themselves. So 1 milliequivalent drop in serum. Yeah. So if you want to estimate the total body potassium deficit, there's a formula that you can do that and help to calculate it. Oftentimes what you run into is, though, with a lot of these formulas are that generally they assume no urine output, which hopefully you're not in that position with the patient. So you have to take some of them with a grain of salt in the emergency room, generally getting people started on a big oral dose, unless their critical is sufficient. Okay, so hypokalemia, look at their medicines, get an EKG, treat them appropriately, and make sure that you're checking the magnesium if they're profoundly hypokalemic. Okay, so the next big player in all of this is sodium. Okay, so potassium we said was mostly intracellular, sodium is mostly extracellular. Sodium is closely related to total body water, moves in and out of the cell, and then there's a sodium potassium ATPase transporter that helps to try and keep everything even. Nephron or whatever kidney part you want. So remember you've got that renin, the renin-aldosterone system that helps to manage homeostasis in your water balance, antidiuretic hormone, and we'll be talking a bunch about this as we go along. Normally ADH is your big player for how your kidneys regulate your free water, and we can do lots of stuff to get that out of whack. So I said earlier, whenever you think about potassium, think about kidney. When you think about sodium, think about water. Okay? So oftentimes with abnormality of sodium, it's really an abnormality of the water that's led to the abnormality of sodium. So remember, lab tests are concentrations. So another one of my pet peeves is somebody gets in a car wreck and you think they've got some injury and they may be bleeding somewhere, and you call a surgeon who says, what's their hemoglobin? So you right here, if I took a lancet and I lacerated your brachial artery and I bled you all the way out, and we took your last drop of blood and we checked your hemoglobin, what would it be?
Normal.
Anybody?
Normal.
It's normal, okay? So in acute settings, remember that your hemoglobin won't change. Unless I've given you 3 or 4 liters of normal saline, your hemoglobin's still going to be normal. Okay, so remember your lab tests are concentrations, and you can change that. You can change those concentrations by giving fluid, not giving fluid. And with sodium, it's probably as important as anywhere else to remember that water is your big player here. So trying to do a little case, 85-year-old male comes in, decreased level of consciousness. Family says he has a history of dementia, but still does pretty well. He's found, he's urinated on himself, the bite mark on his tongue, you can see his vital signs there. So what do you think probably happened while nobody was looking?
Seizure?
They've had a seizure, kind of coming around, probably still post-ictal, based on the family description of his dementia. And then lab calls in, you've got a sodium of 103. Okay? So with profound hyponatremia, you can get neurologic changes and in some cases even seizures. Generally speaking, the risk of seizure starts to go up when you get below 120. Although that's a bit of a relative term, so it depends on how quickly it took you to get there. Okay? So if you quickly go to 124, then you may have neurologic changes. If over weeks to months, a patient goes down to 120, they may not have neurologic symptoms. So it all has to do with the time. Just like we said with potassium, you want to make sure that it's a real value. Make sure that this didn't get drawn through the same line that they were getting their B5 half normal or something else that may have diluted their sample again, because labs of concentration. And then also, you have to look, they can get a fictitiously low serum sodium based on their glucose. So if they're hyperglycemic, there's a formula you can use for calculations. So they get a 1.6 millimole change for every 100 change in their glucose over 800. Okay? If their glucose is 200, then you need to add 1.6 to their serum sodium. Okay? So at that point, when the glucose gets that high, it is taking over more of the osmotic role in the serum, and so it will dilute down that sodium inappropriately. The key points: does the patient have neurologic changes, and what is the patient's volume status? So we're going to get off in the weeds a little bit with this, and then I'm going to put you back out of the weeds because I'm not very good in the weeds. And we'll talk about kind of real world stuff, okay? So you want to make sure that it's real, and then you want to see what their volume status is. So in a hypervolemic state, you'd expect to see pitting edema, the patient looks volume overloaded, they may sound wet, they have a decreased effect of their circulating antidiuretic hormone, they get increased water, so these patients are hypervolemic. So think about this in heart failure, liver failure, kidney failure, things where they're keeping more water than they are sodium, and so they dilute their sodium down. Okay? The next thing is euvolemic hyponatremia. So now they're not really volume overloaded, but they have kept more water than they have salt, and so they'll be hyponatremic as well. We'll see this in a flow chart in a minute that may help. So one of my favorite words in medicine, actually covered a couple of my favorite words. So beer potomania. So what happens with that is you have to have some solute to get rid of free water. So your body can't just pee out straight H2O. So you have to have some solute that the kidneys can put with the water in order to pee it out. But if you're just drinking alcohol, which I'm sure no one in here does, because it's a good, this United Methodist, right, school?
I don't even know.
United Methodist, I'm from the separated Christian church, so I don't know about all this United Methodist stuff. But anyway, so you have to have some solute that you can put into the urine. If you're just drinking alcohol, then there's no protein or other solutes that the body can put in there to draw some of that water out to pee it out. Same thing with a tea and toast diet. Anyway, you may see beer potomania, and you'll see that chronic alcohol abuse can lead to hyponatremia, and that's how it is. Then you can have hypovolemic. So these patients don't have enough water, but still have low sodium levels. So here's a way to look at that I think is a little bit easier. So if we have a hyponatremic patient, we look at their volume status. If they're hypovolemic, think about some kind of renal loss, GI losses, excessive sweating. Maybe they've had some injury that they've gotten a lot of, you guys learned the term insensible water loss. So that's like burns where people are just kind of weeping fluid. You'll also see that term used tachypnic patients. Get insensible water loss. The way I explain it to parents is when it's cold outside and you breathe and your breath fogs, that happens all the time. It's just when it's cold, you can see it. And so if you have a little asthmatic kiddo and they're real tachypnic, so their respiratory rate maybe normally is 24 and they're breathing 48, they're losing twice as much fluid that way. It's mostly free water, but that you get insensible water loss, which is what can happen in burns as well. Then euvolemic, so the syndrome of inappropriate antidiuretic hormone. How about psychogenic polydipsia? Have I heard that term? Yeah. So I've seen this in Shawnee. They have a. Anybody from Shawnee? There's an Indian clinic out there, and they have. I don't know if the Native American psychiatrist only works there or what, but there would seem to be a large population there, and lithium is cheap, and so a fair number of patients were on lithium. So this lady was on lithium, which can also mess up your renal physiology, but the lab called and said, sodium 118. I was like, that is just odd, but she's odd. So I walk in the room, and there's like 6 empty cups in the room. I was like, where is this coming from? And so she had just been on her button, having the text bring her water. So it's usually a combination of something. It would be difficult to just drink enough water to get yourself hyponatremic and get in trouble, but it can happen. Again, it's usually a combination, but it can be seen also in endurance athletes. So somebody runs a marathon and is only hydrating with water. Those patients can get profoundly hyponatremic because they're not replacing the sodium. How about MDMA? Anybody have any experience? So that's ecstasy, party drug. It actually stimulates antidiuretic hormones, so you reabsorb a lot of free water, and then also stimulates thirst. And so these patients are usually hydrating with hypotonic solutions at the club, and they can get hyponatremic as well. And then hypervolemic states, you got cirrhosis, CHF, or kidney problems, you get hypovolemic. SIDH, think about CNS tumors, remember tuberculosis, I told you, diuretics, chemotherapy. Another agent that seems to be increasingly causing this are SSRIs, so Paxil, Zoloft, serotonin, reuptake inhibitors can cause this as well, and tons of people are on those medicines. So, like the case that got presented at the beginning of this 85-year-old male. So working in the emergency room, when you get that tick where it's an 85-year-old male who's not right, there's 2 things you're always hoping for, and that's either urinary tract infection or hyponatremia. So it's just super vague. There's nothing that really says this is what it is, this isn't what it is, but if it's hyponatremia, I know what I can do for it. If it's a UTI, I know what to do for it. If it's something else, it gets kind of messy, and sometimes old people just don't act right. Nausea, vomiting, oftentimes goes with it. They get weakness, neurologic changes, like we talked about earlier. Always consider sodium abnormalities in patients with altered mental status. Acute hyponatremia, usually less than about 120. You start to see neurologic changes. And like I mentioned earlier, those chronic hyponatremic patients may be better. So pearls, when we talk about treatment, if there's no neurologic symptoms, volume resuscitate if they need it. So if they're hypotensive, tachycardic, you may need to give them some fluid. Otherwise, saline lock, keep them in PO, put in a Foley, and don't do anything else. And also remember, if you replace their potassium, that can increase their sodium as well. And we'll talk in a minute about why that's important. So, do you guys listen to podcasts? Are you podcast people? Anybody? No? No, that's spell flat then. So, if you're interested, there's a podcast, there's a guy named Scott Weingart who does a podcast called IMCRIT. He has a great talk on treatment of acute severe hyponatremia.
What
And
is
he
it called?
really kind of breaks it down.
What is it called one more time?
IMCRIT, EMCRIT. If you just Google IMCRIT hyponatremia, it comes up, because I always do that. So his suggestion is, resuscitate them. If they have neurologic symptoms, treat that, we'll get to it, and then order a bunch of labs. Okay? So obviously you want to see what their electrolytes are, but you probably do that. That's why you're already thinking this way. You want to check serum osmolality. You want to check serum uric acid. That can be elevated in some of the endocrine causes of hyponatremia. Go ahead and get a TSH, get a cortisol, check urine electrolytes, urine osmolality, urine creatinine. And the important thing is try and get all of these things as soon as possible, because once you hydrate a patient, once you give that patient anything, you can alter these values and make it more difficult for your nephrologist upstairs to figure out what's going on. Okay? So if at all possible, if there's some lab that is still in the room that didn't get sent up, you want to use that. And then you want to put in a Foley catheter, because even if you give them some saline for a little bit and they start peeing, now you've changed what the kidneys saw and you've changed what the kidneys are doing. So you want the earliest urine sample, the earliest blood sample that you can. I think that's probably good for you guys to study on rather than us to go over all together. I'm not that good with the stick pointer. So if they have neurologic treatment, neurologic symptoms, then you need to treat it, and we'll talk about that. Also, do you guys know, you guys heard of the rule of sixes? Okay, so what is that? You nodded, you should have nodded.
It's right here.
Fair enough. Okay, so obviously there's the rule of sixes. So why did that come about? Who cares about how quickly we raise it? You pointed, you shouldn't have pointed. What's that?
Increase cranial pressure?
Maybe eventually, but there's a term for it.
What's the question again?
There is an encephalopathy. So you may have heard it as the central pontine myelinolysis. Does that sound familiar? No. Okay. The newer term is osmotic demyelinosis, because what can happen is if you correct it too quickly, you can change the osmolarity in the brain and start to demyelinate brain tissue. The one that had been reported and been the most feared was pontine demyelination, which you can imagine is bad. But it can occur in other places. So it had become a little bit of a misnomer that as long as your pons were okay, it wasn't the sodium that caused it. So they kind of come up with a new word. Part of getting old is they keep coming up with new words for the same thing, and I have to learn stuff, which is a pain. But
They're worried about which one's going to be important.
yeah, and I don't know. Yeah, if you see sodium and demyelination, that's bad. Just know that and pick that one. Unless TB is an option, and then pick it. And this came out of this article that was in the American Journal of Kidney, is that replacing 6 milliequivalents in a day, and that gives you some fudge room because it can be a little tricky to predict that, or 6 milliequivalents in 6 hours if they're having neurologic symptoms. All right, so here's how you do that. So if the patient's seizing, profoundly altered in front of you, you can give 100 cc's of 3% saline over 20 minutes is the recommendation. If they're seizing in front of me, they're probably getting it a little faster than 20 minutes. You may hear 3% saline called hot salt, because it sounds sexier than just 3% saline. But 100 cc's of hot salt over 20 minutes, you can raise their serum sodium by about 2 milliequivalents per liter. Remember, our goal is to not go any faster than 6 in 6 hours if they're seizing or having severe neurologic symptoms. And so 2 is well within that. So you give them, you can repeat that up to 3 times to get them to stop seizing, and then you stop. Okay? The other thing is, don't forget that Grandma may have gotten hyponatremic, which made her weak and confused, and she tripped on the cat and fell and hit her head and got a subdural, and now she comes in with a serum sodium of 118, having a seizure, and before everybody high-fives and spikes the chart, remember, you probably ought to scan their head and make sure that they don't have something else going on as well.
If they are seizing in front of you, but you know this is the problem, would you not try to stop the seizure with a different medication? You would never do this?
If I know that their serum sodium is 118, I'm probably going to give both. But no, it's their sodium. Okay? If they fell and have a big hematoma on their head, then maybe it could be something else. But you want to correct this first. Problem is, nurses can pull Ativan out like it's almost in their back pocket. Getting hot salt is going to take a little bit. So do you guys know if you're somewhere, and I'll tell you another kind of cruel irony for those of you that want to do emergency medicine. I tell our residents whenever they start moonlighting, it's a cruel irony in medicine. What we do is we take the people with the least amount of experience, we put them in the place with the least amount of support and tell them good luck. So you guys are probably going to be somewhere that at 2 o'clock in the morning getting hot salt from pharmacy. May have to call somebody in, I don't know. But do you guys know something that every ER has that could accomplish a similar thing? So sodium bicarb. Okay, so every crash cart in America has an amp of sodium bicarb. So if you give 40 mils of that amp of sodium bicarb, it'll get you about the same number of milliequivalents of sodium as 100 cc's of 3% sodium. You need to be careful because it's got to be given over 10 minutes, which is the recommendation. I've pushed an awful lot of sodium bicarb and not had problems with it that I'm aware of. But you need to do a slow push and give it over 10 minutes. But every ER is going to have some sodium bicarb if you need it.
Do anything about their acetate balance?
Probably not, because at that point they're seizing, and so seizures make people acidotic. You may change their pH just a little bit, but 1 amp of sodium bicarb is going to make a difference. It's tough to order acid from the pharmacy too. Okay, so rapid overcorrection, you can get osmotic demyelination syndrome. If you increase it over 10 in 24 hours, you increase the risk. So the number 6 that we gave earlier is a safe number. It gives you some fudge room. In the podcast, Scott Weingart talks about in hyponatremic patients, treat the neurologic stuff. If you need to, give hypertonic saline. Then order a bunch of labs. And step 3 is don't do anything. Don't give them IV fluid. Avoid that temptation because it seems like you should, unless they need volume resuscitation. It seems like you should just give them some normal saline and you'd help correct it. Problem is sometimes that extra amount of fluid can rapidly shut off their antidiuretic hormone, and so they get a free water diuresis much more rapidly than you would expect. And whenever they get that free water diuresis, remember your lab's concentrations, so now we're losing more water than we also are salt, and you can correct much faster than you expect. His step 4 is what to do when you couldn't do step 3. So if you do overcorrect somebody, you can give DDAVP to block the release of that free water, hopefully slow down that correction, and then call neurology or nephrology and apologize. So here's the central pontine myelinolysis, which is kind of the old term, but everybody knows what it means anyway. Yeah, so if they're shocky, you may need to give them some normal saline. Don't give half normal or quarter normal or certainly D5W because that's just free water, right? So you would want to use normal saline if anything, and then fluid restrict them. Okay, put in a Foley catheter. It's probably your best bet if you have a nursing staff and a patient that can judiciously monitor somebody's urine output. You might not need a catheter, but that Foley can help you tell if they're all of a sudden starting to have a big diuresis. So if they start putting out more than 100 mils of urine an hour, you probably need to send off a serum sodium and find out what's going on with that. So, case we talked about earlier, so you give hot salt, may need a second dose, monitor electrolytes every 4 hours. So this is the case that you're probably going to see in the ER. So a 62-year-old female, nausea, vomiting, diarrhea, family says they've been confused. So they're diabetic, they have hypertension, CHF, lung cancer, they're on Zoloft, they're on hydrochlorothiazide. Basically, every line of that has a reason that they might be hyponatremic. So, you know, it's kind of nice on test where there's one answer, but I'll tell you in real life, it's usually this whole schmutz of things all rolled up in a nice big schmutz ball that you got to figure out, right? So nausea, vomiting, diarrhea can cause it. You know, if they're hyperglycemic, that can cause it. If they have hypertension, they're probably on hydrochlorothiazide, so that can cause it. If you have lung cancer, if you have a small cell cancer, maybe you got inappropriate SIADH from that. SSRIs can cause it, so this is oftentimes what we end up seeing. So from the ER side, I really like Weingart's approach of order a bunch of lab and then do nothing. Yeah, so, well, what are you gonna do with that? Yeah. And then if she likes going to raves, then you gotta worry about MDMA, and it gets even worse. Hyponatremia, correct if they have neurologic symptoms, that's how you can do it. Remember the rule of 6. Don't demyelinate anybody. DD, AVP if you overcorrect.